My name's Joyce and I'm an anaesthetist from Brisbane, Queensland. I'm extremely privileged to be here today with Associate Professor Chris Connor, who is the Vice Chair of Research at Brigham and Women's Hospital. He's also a practicing anaesthesiologist with an interest in neuroanaesthesia and holds an MD PhD specialising in biomedical engineering and physics. Thank you so much for being here today.
Good afternoon, Joyce.
Congratulations on such an engaging and thought-provoking plenary lecture looking at reverse engineering the BIS. Can I ask in what way this has since changed your own clinical practice?
I think that the role of technology should be to serve the anaesthesiologist or the anaesthetist. And so I've always wanted to know how the device functions, because if it proposes to say whether or not a person is unconscious or not, that's a big claim to make, and I want to know how that claim is justified so that I can make it work for me. I don't want to just serve the machine. So for me, the most important thing was just knowing how the algorithm works so that you can judge what it says appropriately in the whole clinical context. So not just to be a servant of a number that goes up and down, but to know how to take that information or that evidence about the patient's clinical condition and weigh that in with all the other data that you see. So I think it's important to know how it's affected and how it changes. And then once you have those algorithms, then you can try to use them for other things. And so we have a paper that just came out in Anaesthesiology looking at alternative versions of the algorithm that you might be able to build that could try to assess whether patients might recover after they've had a cardiac arrest, they get resuscitated, they don't wake up yet. Will they ever wake up? It would be really nice if we had an algorithm that would help us know how to advise those patients' families or guide their treatment. So that's one of the things that I now hope we can do once we know how the algorithm works in more detail.
And in using that EEG-based model in predicting neurological outcome, what did you find were predictors of neurological recovery in the subset of patients you studied?
Yes, so there are some features that you would kind of expect to find going in, and the neural network does pick those up. And it's always reassuring when it does something that you kind of hoped or expected that it might do, because then it helps you feel more comfortable about the results. So one of the things it looks at is burst suppression, or a measurement very closely related to burst suppression, because obviously patients who have a large amount of burst suppression don't have good prognosis. So you would expect that. It also looks at the overall amount of power in the EEG that's coming out, and low power states are also obviously not predictive of good outcomes, and that's something that you would expect as well. One of the things we saw that neurologists have not been using is more of a dependence on the gamma band. So frequencies in the range of 30 to 47 hertz, and there's some belief that those might be related to the connectedness of consciousness. And that was something we hadn't seen before that did pop out from harvesting the EEG using these emulations of BIS monitors. So that's kind of exciting. I have to temper it a bit because I have to say, it's a single center study done with about 400 patients, done retrospectively, done with a neural network. So we still have to come to terms with exactly what the neural network thinks it's finding. So I want to be a little careful about judging my own results, because the first person you deceive is always yourself. You're always hopeful you'll find something, and then you do, and then you have to hope that it stands up. So we have to go multi-center, maybe international, test it with more patients, see whether what we found really will hold up. But I am very happy with it so far, because I think it's a clinical need that is unsatisfied, where as anaesthetists we can potentially reach out and help those patients and their families.
One of the things you mentioned just now was about making technology work for us rather than the other way around.
Absolutely.
And perhaps where future developments in this sphere might lie.
Yeah.
I did note that you have a recent publication in Anaesthesiology looking at machine learning architecture and examining sort of the transformative potential of generative AI.
Yes.
Where do you think the line draws between AIs then becoming a hindrance rather than really a help, and perhaps the limitations as to what its utility might be?
I think the anaesthesiologist remains at the centre of the care. And I guess to bring back my earlier point, the technology is there to serve the anaesthesiologist, just as you work and give of yourself in order to have medicine serve the needs of the patient, not the other way around. So I think provided you have the feeling that the technology is working for you, whatever it is, then that's fine. But if you have the sense that the technology is constraining you or straitjacketing you into doing things that you don't want to do for the patient, well, then you have to draw the line right there and say, no, that's misguided. That's not how I want it to be as a clinician taking care of a patient. And I think you have a responsibility to yourself and to the specialty and to your patients to make that step when you have to.
There's certainly very exciting times ahead. Thank you so much for your time. I know that you're dashing off to give another lecture shortly, so thank you again, and all the best on your journeys back home.
Thanks, Joyce. It's been a great pleasure to be here with you all in Cairns.